High blood pressure is common among people with type 2 diabetes. Now, ideally, you would want a treatment that can positively affect both blood glucose control and blood pressure, and that is what we are here to discuss at the AHA meeting in Orlando, Florida. I'm with Dr. Raymond Townsend, MD, who is the director of the Hypertension Program, hospital of the University of Pennsylvania and a professor of medicine there, and Dr. Katherine Merton, who is a PhD MBA, integrated evidence team lead at the Medical Affairs Department at Janssen Pharmaceuticals. First off, thank you very much. This is kind of exciting as we're talking about an agent that kind of solves two big problems, treats two of the big problems that we have today. Who wants to go first in terms of, let's talk about the agent itself before we talk about a study?
So I can lead off. I always wanted to bat first in the order. So the issue with diabetes is really predicated on the following. Of all the blood glucose lowering drugs we've had from the 1960s onward until very recently, there has yet to be a drug that lowers glucose and reduces the risk of death. And that has been one of the holy grails in the whole diabetes field. But as of this year, a new class of drugs has been shown in a large outcomes trial to not only improve blood sugar control, but it also lowers blood pressure, it drops body weight, and it also improves the outcomes of death and hospitalized heart failure, two of the biggest risks that are present in diabetics that have high blood pressure.
Kind of a medical grail.
Well, it's actually, when I first heard about this class of drugs, I thought, it's too good to be true. You lose weight, your blood sugar comes down, your blood pressure improves, and you make the best sausage lasagna ever. So that particular attractiveness just seemed a tiny bit too good to be true. And here I am 2.5 years later, I'm eating my words because now there is actually data to support not just the features of glucose lowering, blood pressure lowering, weight lowering, but the benefits associated with that.
Now, what's the science? Where are you targeting that you're getting so much benefit?
So canaglifozin targets the SGLT2 transporter. It primarily acts in the kidney, and that's how it enables the reduction of glucose, the level of glucose in your bloodstream, mainly by increasing the amount of glucose which will come out in your urine.
As a matter of fact, when the kidney normally, and it normally does, filters glucose, it reabsorbs all of it, so that any glucose appearing in the urine is abnormal. But there was this weird, rare disease in people called renal glycosuria, where you would have a urinalysis done, the thing would come up positive for glucose. Like, how long have you had diabetes? Oh, I don't have diabetes. Oh, this dipstick says you do. And it turns out there was a very small group of people who normally lose a little bit of glucose in the urine. But it turns out they've got no sequelae, no consequence of that. They live a happy, normal life.
Right.
And so if you could understand what it is to put the glucose in there in the absence of major side effects associated with that, you might have a very interesting drug. Okay. And like most things, where do we go? Bark of a tree. So we go to the bark of the pear tree and the apple tree, which has a compound in it called fluorizin. And it turns out it's been known for decades that fluorizin impairs the ability of the kidney to reabsorb filtered glucose. Drum roll, thus we have the potential mechanism to eliminate glucose from the body at the level it is in the blood. So if it's higher in the blood, you get rid of more. And if it comes down in the blood, you get rid of less. So it auto-corrects. And the beauty of that is that it would reduce the likelihood of hypoglycemia, which is one of the things that plagues insulin therapy in particular.
Now, the presentation here, what's the data and what did you do and what did you find?
So there have been actually two presentations here. I gave a talk yesterday morning about new methods, new interventions in blood pressure control, and I talked about the large outcomes study using an SGLT2 inhibitor that was done in about 40 countries and over 7,000 people that demonstrated the cardiovascular benefits. Tomorrow afternoon, I have a poster to present that took roughly 160 or so patients with diabetes and high blood pressure, and using the best tool we have for blood pressure measurement, a 24-hour blood pressure monitor, takes a bunch of times during the day and the night for a full day and night, and patients in the study, participants in the study, wore this thing about a week before they were randomized. On the day they were first dosed, which is the unique thing about this study, and then 6 weeks later. So they got, and they're diabetic, so they're already on diabetes agents and on blood pressure medicines, but they're randomized to a placebo, to a 100 milligram or a 300 milligram dose of this particular SGLT2 that's called canaglifozin. And what we found is that you see a bit of blood pressure reduction on the first day you're treated. That's been unknown till now. And it is sort of interesting that it would act so quickly. But what we didn't see is people falling down from lightheadedness or, dropping out because their blood pressure was way reduced. That was a safety issue that hopefully we've laid to rest with this class. But at the end of 6 weeks, we found a significant reduction in ambulatory pressure monitoring that was dose-related, which is what you like to see in these kind of studies. So 100 had a good effect, the 300 had an even better effect, and placebo had virtually no effect, which is the value of ABPM because you can do smaller numbers because there's virtually no placebo benefit in ABP monitoring.
What kind of responses did you get in terms of clinically relevant?
So about a 5 millimeter systolic blood pressure reduction, which on an ambulatory blood pressure monitor is huge with a capital H. That's not a, an almost kind of thing, or like a barely clinically significant, or from a population level, somewhat important. 5 millimeters is take it home.
And what about on the glucose side?
So and there was improvements in the A1C and those kind of trappings as well. Not as big a attraction to me because there's lots of ways to improve overall glucose control, but fixing the blood pressure at the same time, to me, that's the take-home message.
Okay, what's next?
Outcomes. So bigger outcome trials. One of the things we always want to do is the longitudinal stuff, and especially to look at an underserved population, people with chronic kidney disease. So Janssen in particular is doing a study in diabetic nephropathy looking at the potential value of this class in slowing the progression of kidney disease when it's already impaired, kidney function's already impaired.
Wow. So where is that? I mean, where are you enrolling patients? Is this all being planned? Where are we?
So the Credence study that Dr. Townsend just referred to, that will be reading out in 2019. And we also have 2 cardiovascular outcome studies, CANVAS and CANVAS-R, that will be reading out in 2017 as well.
So what I'm taking away here is bottom line. So after 6 weeks, 300 milligram dose provided a rapid and significant reduction in mean 24-hour systolic blood pressure, and then both doses reduced daytime systolic and diastolic blood pressure, correct? And demonstrated an overall safety profile that was consistent with clinical studies.
Absolutely. But the main thing you see with this class, and there's 2 things, and I made this point yesterday in the oral presentation I gave, is that when you enrich the urine with glucose, well, germs like that, they're particularly fond of having tons of sugar around. So the likelihood of a urinary tract infection is a bit higher. It's not huge, and it's treatable. I mean, it goes away. You continue the meds, and they still are okay. And once in a while, it's candida, particularly in women. So occasionally a yeast infection occurs. But the one potential, it's out there, and we should be aware of it, complication with all the SGLT2s, and it happened in the large outcome study that empagliflozin just published in New England Journal, is a phenomenon called ketoacidosis. And the reason that's important, we know ketoacidosis occurs in diabetics, but in this case, the blood sugar is not elevated. That's the thing. So we have to learn to recognize this this known complication of diabetes and be ready to find it when a well-treated type 2 diabetic comes in feeling poorly, maybe a little bit of vague abdominal discomfort, and their blood sugar is 160, but their bicarbonate is 16, and they are actually breathing a little bit Kussmaolian. So that's the circumstance when we check the urine and maybe the blood for ketones.
So it may be a while, but maybe within a year or so, you might be able to come back and chat a little bit more about where we are?
Absolutely. There'll be more. There's a handful, and canaglifozin is one example of a compound in multiple cardiovascular outcome trials, but there are several others. So there's lots happening in this area, and it's actually exciting because diabetes has been kind of flat with new developments until this came along.
Yeah. And we have a variety of things that we're talking about in terms of the highlights of this meeting. Please check our cover stories in both CardioSource World News and CardioSource World News Interventions, where I'm Executive Editor Rick McGuire.